Welcome to our podcast series on shingles. The goal of this six-part series is to increase healthcare professionals' understanding and awareness of shingles, strive to reduce healthcare disparities and inequities, improve healthcare professionals' performance, and enhance quality of care for patients. During this third episode, we'll discuss the efficacy of the shingles vaccine, safety data, including duration of protection, and the vaccine series completion. As we get started, I wanted to mention that this educational activity is supported by an independent medical education grant from GSK. Recommendations and opinions presented may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA. The AHA does not endorse any product or device. And I'm Andrew Huang. I'm an associate professor of pharmacy practice at the Massachusetts College of Pharmacy and Health Sciences, and joining me is a distinguished multidisciplinary panel.
My name is Johan. I'm an associate professor of pharmacy practice at the Massachusetts College of Pharmacy and Health Sciences in Boston, Massachusetts. I'm also a practicing clinical pharmacy specialist in infectious diseases at Boston Medical Center South.
I'm Dr. Sarah Rendell. I'm a board-certified internal medicine physician and a fellow in infectious diseases at Massachusetts General and Brigham and Women's Hospitals in Boston, Massachusetts. I focus on the prevention and treatment of illness and complications from chronic and recurrent infections, including varicella-zoster virus.
Great. So to begin, let's set the stage with a quick overview of how shingles vaccines have evolved. So can you give us an overview of how shingles vaccines have evolved over time and how we arrived to the current recombinant vaccine?
Absolutely. There's been great clinical interest in developing a vaccine protection strategy against reactivated varicella-zoster virus, also referred to as herpes zoster or shingles. There have been two available to patients vaccines in the past. The first was the live zoster vaccine, which is no longer recommended. It was based on a live and attenuated form of the varicella-zoster virus. Because it was live, it wasn't an option for immunocompromised hosts, and we'll discuss more of the limitations of that vaccine next. Then we have over a decade of data on the AS01B adjuvanted recombinant zoster vaccine, and this was developed to target the viral glycoprotein E. And then finally, there was initially some early phase 3 data on a non-live inactivated varicella-zoster vaccine. Ultimately, this wasn't pursued given the high efficacy of the recombinant vaccine. So overall, just to answer your question, Andrew, given the superior efficacy of the recombinant vaccine, particularly in older patients who are more vulnerable to zoster and its complications, and therefore the focus of our prevention strategy, the live vaccine has since been phased out.
And great context. So now that we understand sort of the evolution of the vaccines, let's kind of dig a little bit deeper into the science behind them. What are the key differences between the live zoster vaccine and the recombinant zoster vaccine?
Very important question. So first, the live zoster vaccine, again, developed based on a live inactivated form of the virus, had some modest short-term efficacy that did wane over time, given that it was a live vaccine, wasn't safe or suitable in immunocompromised patients. And the immune response to the live zoster vaccine, abbreviated sometimes as ZVL, was very age dependent, meaning that older patients tended to develop less of a protective immune response. So then the recombinant zoster vaccine, which is what we recommend today, did have superior efficacy to the live vaccine. And then most importantly, conferred protection that's not diminished by age of the patient, and then elicits a durable immune response. An additional benefit to this vaccine is that it has been demonstrated to be safe and immunogenic in immunocompromised patients.
Great. So now that we understand sort of the differences between the vaccines, let's look at how the recombinant vaccine performed in the clinical trials. So what have we learned about the vaccine of efficacy from the major clinical trials, such as the Zoe 50 and the Zoe 70?
Wonderful. So exactly, Zoe 50 and 70 are two placebo-controlled clinical trials of the recombinant vaccine. We have now just over a decade of data on the recombinant zoster vaccine, beginning with these trials. So these were completed and published in 2015 and then 2016, named Zoe 50 for patients 50 years of age and older, and Zoe 70 for the 70 years of age and older groups. Combined, these trials included more than 30,000 participants, of whom around 16,500 were 70 years of age or older, and therefore contributing to Zoe 70. So overall, to summarize, these trials demonstrated remarkably high clinical efficacy against herpes zoster in both age groups, with a median follow-up of about 3.2 years, also demonstrating durable protection. And in the 70 years of age and older group, these initial trials demonstrated more than 4 years of durable protection. And to put a number on what I mean when I say high efficacy or superior efficacy, I'm talking about an overall clinical efficacy in preventing herpes zoster events of 91% or greater. And then, we can talk a little bit more about different correlates of efficacy, but even better efficacy in later analyses against post-herpetic neuralgia, specifically in the 70 and older group.
Those are really impressive results. And so if we compare that with the efficacy of the live zoster vaccine, how does that efficacy of the recombinant vaccine compare with the efficacy of the live zoster vaccine?
Yeah, so, in terms of prevention strategies, this is probably I will say from a clinical perspective, one of the best results we could have hoped for. So I will focus, when we say efficacy, we can talk about immunologic efficacy or clinical efficacy. When it comes to zoster, I'm going to focus on the clinical efficacy. In other words, how well do these vaccines prevent herpes zoster and post-herpetic neuralgia? And the reason I do this is, we have to interpret humoral immunity or antibody responses with caution, because that's not the main determinant of protection against varicella zoster disease. Cellular immunity is. So to answer your question, Andrew, compared to the live zoster vaccine, the clinical efficacy of the recombinant zoster vaccine is much higher. So for the recombinant zoster vaccine, again, 91% or greater, and sustained even beyond the 4 years, which we'll talk about a little bit later in the long-term follow-up study. And this is compared to an overall clinical efficacy against herpes zoster of about 50% in the live zoster vaccine. And as I mentioned before, but it's worth emphasizing, the live vaccine is less effective the older the patients are, and the protection that vaccine offered waned rapidly over time. So the 2-dose recombinant zoster vaccine is about as effective as we might hope a vaccine strategy could be against varicella zoster reactivation.
Yeah, thank you for that explanation. And so we also know the recombinant vaccine is used in immunocompromised patients and as well as medically complex patients. And so let's kind of touch on that a little bit next. So what does the evidence say about the recombinant zoster vaccine effectiveness in immunocompromised patients?
This is probably one of the most frequent questions I receive in the clinical world, because I think people have learned that the live vaccine is contraindicated in immunocompromised patients, but the recombinant vaccine is not. And there was subsequent data in renal transplant recipients looking at immunogenicity and safety, as well as in patients with hematologic malignancies on chemotherapy. So I'll just highlight a few points. In the autologous stem cell transplant recipients, the Zoe HSCT trial showed about 68% clinical efficacy against herpes zoster in this immunosuppressed population, and 89% clinical efficacy against post-herpetic neuralgia. And again, that was Zoe HSCT. And then in participants with mild immune-mediated diseases such as psoriasis, a pooled post-hoc analysis of Zoe 50 and Zoe 70 demonstrated about 90.5% efficacy in prevention of herpes zoster. And then I'll highlight just a few other things. So in solid organ transplant recipients, clinical trials and then multiple observational studies have shown a robust humoral and cell-mediated immune response to the recombinant zoster vaccine with durable glycoprotein E-specific CD4 T cell responses, which, as I mentioned, is the primary determinant of protection. And these studies also importantly demonstrated no increase in organ rejection or immune-mediated adverse events. I would also mention a caveat, which is that immunogenicity was found to be limited in the allogenic stem cell transplant recipients, knowing that this is just immunogenicity measures, not direct measures of clinical efficacy.
That's really great information. And another area that seems to be sort of growing with the shingles vaccine is the benefits that may be beyond the zoster itself. And so, what does the evidence say about the potential cardiovascular benefits of shingles vaccine?
So, I'll try to summarize what is a large and growing body of work, and this has generated a lot of interest. I will start by saying that we know, longstanding research on the varicella-zoster virus demonstrates that it is a vasculopathic virus. And that matters because when you talk about cardiovascular benefits, we always have to think about what could be a physiologic basis of these benefits. Herpes zoster itself is associated with an increased risk of heart attack and stroke. So, for example, in the month following a zoster attack, the risk of stroke is about 2 times, or rather 1.9 times higher. To give a sense of some of the observational data out there, in a matched cohort study of more than 500,000 adults who completed both doses of the recombinant zoster vaccine, 2-dose completion was associated with a 30% reduction in heart attack and a 43% reduction in stroke. And this is compared to unvaccinated patients. This finding then has been consistent, very consistent across numerous observational studies in different contexts and patient populations. There's a lot of interest, especially in the past year, on the relationship between the recombinant zoster vaccine and dementia. So I'll briefly mention that data. There are theories that the varicella-zoster virus and potentially herpes simplex virus may lead to dementia, though this hasn't been mechanistically demonstrated. What we have seen is that the recombinant zoster vaccine has been associated with a marked reduction in the incidence of dementia. We need more research, though, to establish the mechanism of this association.
And those are very exciting results, and it's amazing how much kind of new data has come out in regards to the shingles vaccination after how long it's been out for in the market so far. So now let's kind of shift to the duration of protection, something that a lot of clinicians and patients often have questions about. And so, what do we know about so far about the long-term protection? How long the protection lasts after completing the 2-dose recombinant vaccine series?
Thanks, Andrew. I think that's a really great question and something that's of interest to both clinicians and patients. Dr. Randall has summarized results of the pivotal phase 3 studies, so both Zoe 50 and Zoe 70, which has demonstrated that the recombinant vaccine not only has high immunogenic efficacy, but most importantly, clinical efficacy as well. And the median duration of follow-up in those trials were about 4 to 5 years. And most recently, the final analysis of the open label phase 3B long-term follow-up study was published. This study included more than 77,000 participants from the Zoe 50 and Zoe 70 trials, and those participants were followed up to approximately 11 years post-vaccination. And we know from the results of this long-term follow-up study that the recombinant vaccine demonstrated vaccine efficacy against herpes zoster of approximately 80% in patients aged 50 years or older, and efficacy of exceeding 70% even in individuals who are vaccinated at 70 years or older. And over the same duration of follow-up, vaccine efficacy against post-herpetic neuralgia, which is, of course, a complication of shingles that we often worry about as clinicians, was also exceeding 80%. So all in all, I think the long-term follow-up study provides us with reassurance and evidence that the recombinant zoster vaccine provides durable protection against herpes zoster and its associated complications.
It's really great. It's great to know that the protection is expected to last for many, many years. And so, and what about the immune response behind that protection? What do the long-term follow-up studies shown regarding the immune persistence?
Yes, so the long-term follow-up study also looked at the persistence of humoral and cellular immunity following administration of the recombinant zoster vaccine. And they found that antibody concentrations remain stable from 5 to 8 years after a vaccination. They do see a slight decrease at year 9, but that remains stable all the way till about 12 years of follow-up, which is currently what we have data for. And similarly, what is important as far as shingles is concerned is the cellular immunity. So looking at T cell frequencies that also remain stable during the study duration for the long-term follow-up study. So again, this study, I think, provides the evidence of the long-term immunogenicity and also the durability of the recombinant vaccine.
So great. So we don't have to worry too much about the persistence waning over time, and so clinicians and patients can be pretty confident in the vaccine. Um, so let's move on to the topic of safety and tolerability, which is another topic that a lot of clinicians frequently discuss with patients. And so, what are the most common side effects that patients experience after receiving the recombinant zoster vaccine?
Yes, definitely. I think safety considerations is something that patients often have questions about. And overall, the recombinant zoster vaccine is pretty safe for patients. And the most common side effects that patients might expect would include injection site reactions like pain, redness, or swelling. Some patients may also experience systemic adverse effects like fatigue, muscle pain, headaches, or fevers. These side effects we see more commonly in younger patients as compared to older patients. But fortunately, most side effects are mild to moderate in severity and usually resolving on their own within about 2 to 3 days after vaccination. And in real life, most patients who receive this vaccine reports experiencing these side effects for about a day.
Thank you for sharing that. And you know, a lot of times you hear that the recombinant vaccine is more reactogenic. And so, what does that mean when the recombinant vaccine is considered to be more reactogenic? And how can clinicians set expectations for their patients?
That's really a great question. Reactogenicity, I think, is a term that comes up frequently when we discuss the recombinant zoster vaccine. So this is a term referring to how likely a vaccine is expected to cause certain short-term symptoms or adverse effects after administration. And the recombinant zoster vaccine is reactogenic because approximately 80% of patients report experiencing symptoms after administration. And the reactogenicity of the recombinant zoster vaccine is related to the presence of the AS01 adjuvant, which is present in the vaccine, and the presence of this adjuvant is precisely the reason why this vaccine is highly effective at boosting immunity and is also what allows the vaccine to overcome the weakened immunity that may come about with age and other forms of immunosuppression. However, the presence of this adjuvant is also responsible for the common side effects that we might see associated with the vaccine, including the injection site reaction and systemic reactions like fevers and muscle pain. So I think in practice, it is really important for clinicians to normalize patient expectations by letting them know what they might expect following vaccine administration and why those symptoms might occur. So something that we can tell patients that's easy to understand. For instance, in a vaccine, it is the antigen that we want our immune system to learn how to fight and how to contain. So patients can think of the adjuvant as a pamphlet, essentially, that our immune system is trying to learn to read. And the adjuvant that is present in the vaccine acts essentially like reading glasses that helps our immune system to read this pamphlet more clearly and more effectively and learn what's there and remember it for the longer term. So it is normal for patients to experience pain in the arm, to feel tired, and maybe experience some fevers after the vaccine. And in fact, this reaction might be an evidence to the patient that the immune system is trying to learn how to recognize the virus and learn how to protect you in the longer term. And these side effects usually last for about a day, and after which you are back to where you were before.
Perfect. And normalizing a lot of those side effects and setting those expectations to help patients understand, what's going on and why that's it's important as part of the vaccination process. Sometimes patients may be concerned about whether side effects are lasting too long or what kind of side effects to be concerned about. And so what kind of what recommendations do you have when it comes to what clinicians and patients should be concerned about when it comes to side effects?
Yes, as mentioned, so in clinical trials, the typical duration of side effects is about 2 to 3 days. And in real life clinical practice, I would say most patients actually are at the lower end of this range, with side effects largely resolving on their own within a 1 day time frame. And meanwhile, the over-the-counter analgesics like acetaminophen or ibuprofen can be used for managing these side effects. Clinicians and patients should be mindful of more serious adverse reactions, such as allergic reactions, including rash, itching, or flushing. These adverse effects are rare. They had not been reported in clinical trials, but we do see these reactions being reported as the vaccine becomes commercially available and increasingly used.
So now let's kind of wrap up with the key practical challenges when it comes to the vaccination. So ensuring patients are able to complete both doses. And so why is it important, or why is completing both doses for the recombinant zoster vaccine so critical for achieving the full and durable protection?
That's really a great question, Andrew. So we know that the recombinant zoster vaccine is administered as a series of 2 doses, and the recommendation is that the 2 doses should be separated by 2 to 6 months. It is really important for patients to receive both doses because vaccine efficacy is significantly higher when patients receive 2 doses as compared to those who only receive the single dose. And based on clinical trials and real-world studies, we know that vaccine efficacy for a single dose of the vaccine is only about 57 to 62%. This is, of course, quite a bit lower than the 90% that we would expect to see in patients who have received both doses. And in addition, administering both doses is also more likely to offer protection that sustains over time. So for patients who received only 1 dose, we know that protection decreases significantly after the first year. However, from the results of the long-term follow-up study following Zoe 50 and 70, we have seen how vaccine efficacy remains around 80% up to 11 years after completing the 2-dose series.
Great. And sometimes patients may miss that window. And so if a patient is delayed beyond that recommended 2 to 6 month window for the second dose, how should clinicians proceed?
Yes, and that's actually not a uncommon occurrence in clinical practice. So clinicians should go ahead and administer the second dose as soon as possible. There is no need to restart the entire series. So even though the prescribing information for the recombinant zoster vaccine recommends administering the second dose within 2 to 6 months after the first dose, We since have research that demonstrated that the protection after dose 2 will still be really good, even the second dose was administered later or more than 6 months after the first dose. So this is definitely a case where it's better to be late than never.
Perfect. And so we know it's very important to have the full two-dose vaccine series. But what does the national data currently tell us about the completion rates for the two-dose series?
So what we know from the available national data in the US is that for people getting the recombinant zoster vaccine, we have about 3 out of 4, or 70 to 73%, who complete it within the first 6 months. In other words, a 6-month interdose interval. And then we get up to 80%, or an additional 7%, who will complete it within 12 months. The study, the protocol for the immunization was initially studied as a 2-month interdose interval, and then later demonstrated non-inferiority for the 6-month interval. But I would say, we do all right getting patients to get both doses within the recommended time frame, but there's definitely room for improvement.
Yeah, I mean, definitely some room for improvement. Ideally, we probably want that to be closer to 100%, but in real world, that could be pretty difficult. So what are some common reasons patients may not return for their second dose?
Yes, so common reasons patients don't come back for the second dose after they've gotten the first. From experience and also from available studies, I can say that forgetfulness, some patients, get the first vaccine when they're told to. The provider might tell them this is a 2-dose series, but they might forget what that time interval is, or that they even need a second dose at all. And another reason would be underestimating the importance of the second dose. I think in real life, people often think I've already, checked one of the boxes. I've gotten one dose. That's probably enough. In reality, as we've already summarized here, we do recommend getting both doses for the protection that we've discussed. Another reason people don't return for the second dose is actually a lack of knowledge on the part of providers. There are some misconceptions about what are reasons to not get the second dose. For example, one survey-based study of primary care providers found that around 30% of providers believe that having a sore arm or some swelling in the arm is a contraindication to the second dose, which is not accurate, and again shows us room for improvement. Another area that I've noticed in my own clinical practice is that sometimes providers say, well, if a patient has had zoster already, and we're vaccinating them to prevent another attack, they might only need a single dose, which is, again, not true. They need to complete the 2-dose series. Then finally, patients do face barriers to access. This can be transportation insecurity, inability to get to the vaccine. Depending on insurance, some patients can only receive the vaccine paid for at a pharmacy versus at the doctor's office. And then cost barriers as well are sometimes a reason why a patient would only get a single dose. And then finally, we heard from Hun about reactogenicity. And so some patients, faced with a fever or a reaction to the first dose might not want to get the second dose.
Great. And so it sounds like quite a bit of factors, maybe very difficult to pinpoint exactly which factors might be the most important ones, but definitely things that maybe clinicians need to consider when they're trying to have patients complete the two-dose series. So as we kind of wrap up our discussion, sounds like a few key themes kind of really stand out. So one being the difference between the live zoster vaccine and the recombinant zoster vaccine is fairly substantial, and seems like the recombinant vaccine offers much higher efficacy, more durable protection, and is appropriate for more broader range of patients, including those who are immunocompromised. And so this really represents a major advancement in shingles prevention. And second, completing the full two-dose series is essential. Everything that we've discussed, from long-term effectiveness to the protection or the real-world protection, really depends on patients receiving both doses. And then finally, the shingles vaccination really deserves to be treated as a true clinical priority. We have discussed the strong evidence behind that, including a lot of the emerging cardiovascular and dementia benefit data. And then clinicians should really routinely encourage patients who are indicated to receive the vaccine to help reduce patient burden from shingles as well as prevent avoidable complications. So I just want to thank the panel and the American Heart Association. This podcast and future episodes will be available through major podcast platforms. To claim credit, visit learn.heart.org.